would also like to thank you very much for the invitation. And I will tell you a few words about thyroid FNA interpretation criteria and the different classification systems. Thyroid FNA is the first test nowadays to triage thyroid nodules for medical or surgical management. And it has led to a decrease in the number of patients undergoing surgery for benign lesions and to an increase in the detection of carcinoma in surgical specimens. As a consequence, thyroid has become the most popular site for FNA in the past 10 years. So it is very important for the site pathologists to communicate thyroid FNA interpretations to their referring physicians in terms that are clear and clinically useful. And for that reason, two major classification systems have been developed. The first one is the Bethesda System for reporting thyroid cytopathology, which has 6 categories, and it was published after the conference in Bethesda, Maryland in 2007. And each category has an implied cancer risk and recommended clinical management. The second classification system is the Modified British Thyroid Association system, which has updated the Bethesda systems and has 5 categories instead of 6. The first category is the class 1 in the Bethesda and Thy 1 in the British Thyroid classification system, and it is the non-diagnostic unsatisfactory category. So for a specimen to be satisfactory, it has to have more than 6 groups of follicular cells with 10 cells each. And if it is less, then the specimen is considered non-diagnostic or unsatisfactory. This is the quantity of the specimen. Other reasons for a specimen to be considered unsatisfactory, these are the quality of the specimen is poorly prepared, poorly stained smears, follicular cells obscured by blood clotting or the thick smearing technique. If we have cystic lesions with fluid and we have less than 6 groups of follicular cells, then we have to ask the clinician. This is about the clinical findings, and if it is a simple cyst, then we can consider it satisfactory. A few exceptions where no minimum number of follicular cells is required are the solid nodules with inflammation, for example, in lymphocytic thyroiditis, in thyroid abscess, granulomatous thyroiditis, and in colloid nodules when we have abundant watery colloid. And these, in these situations, we consider the specimen satisfactory despite the less than 6 groups that we find. The management is to reaspirate the nodule if it is clinically indicated, but we shouldn't reaspirate sooner than 3 months. This is in order to prevent false positive interpretations due to the reactive reparative changes of the thyroid gland after the FNA procedure. An immediate on-site adequacy evaluation is preferred for repeat aspiration, especially for solid or suspicious nodules. A few probable reasons for inadequate specimens that depend on the nature of the thyroid nodules. These are the sclerotic lesions, for example, scarring in nodular goiter, rheidal thyroiditis, we can see when we have fibrosis in lymphocytic thyroiditis, and neoplasms with marked desmoplasia. When you have thick fibrous calcified capsule and it is difficult to penetrate with the nodule. When you have large lesions with cystic degeneration, here the clinical correlation, as we said, is very important. When we have necrotic lesions, for example, abscess, infarct, necrosis in a tumor, and the very vascular neoplasm, where the specimen is diluted by blood. The second class is the class 2 of the Bethesda or Thy 2 of the British Thyroid Association system. It is the benign follicular nodule, and this is the most common result from thyroid FNAs. It's seen in approximately 65% of cases, and it is associated with a very low risk of malignancy, 0 to 3%. And it comprises a morphologically diverse group of benign lesions ranging from the colloid nodule, which has scant cellularity and abundant colloid, to the hyperplastic adenomatoid nodule with high cellularity and scant colloid. And in these lesions, we have variable amounts of colloid, benign appearing follicular cells, a few hartal cells I will describe later, and macrophages when we have cystic degeneration. And the management is conservative follow-up with periodic clinical and radiologic examinations. These are a few images from cases we had. Here we see the colloid like the broken glass appearance. Here we see a foamy macrophage that indicates the cystic degeneration. And here we have a few follicular cells. Here again we see colloid and follicular cells here. Then again follicular cells, and this formation is called a macrofollicle, which is a sheet of follicular cells that are regularly arranged, and it is an indication for a benign lesion, the macrofollicle. Here again we see macrofollicle, and here we see a group of hartal cells where we see more pink cytoplasm, which are follicular metaplastic cells. The next category is the class 3 or Thy3A of the British classification system, is the atypia of undetermined significance or follicular lesion of undetermined significance. Here the risk of malignancy is 5 to 15%, and it is a diagnostic category of last resort. We try to avoid this category. Here we have some architectural and nuclear atypia that are not sufficient to be classified into the next categories. We will talk about them later. And the most common situations where this category is used is when we have an increased number of microfollicles. The microfollicles are groups of follicular cells, small groups, of 6 to 10 cells, which we see in a follicular neoplasm when it is more than 75%. So if we have about 50-50 macro and micro follicles, we use this category. The second, when you have an almost exclusive population of hartal cells, but the clinical setting suggests a benign hyperplastic hartal cell nodule. For example, in lymphocytic thyroiditis and in multinodular goiter, it is a common situation to have an increase in the hartal cells. When the interpretation of follicular cell atypia is hindered by blood clotting, which causes artificial cellular crowding. When we have a cyst with cystic atypical looking cells with repair changes in an otherwise benign sample, but it is the atypia has to be mentioned. And when we have focal ill-defined atypical nuclear changes, and when we have atypical cells but a history of radiation or carbimazole treatment. The management of atypia of undetermined significance, we have to have a clinical and sonographic correlation. It is very important. And in most cases, repeat FNA will solve the problem. If the nodule is clinically suspicious, sonographically it is a suspicious lesion, then surgery can be considered without a repeat aspiration. And a repeat FNA usually results in a more definite interpretation, and only 20 to 25% of cases are repeatedly housed, and where surgery is recommended. The next class is the class 4 or Thy3F, and what the British Thyroid Association system did is it took the previous class, the 3 and the 4, and it incorporated into one. So the previous, it has the A of the atypical, and here we have the 3F of the follicular neoplasm. It is the follicular neoplasm or suspicious for follicular neoplasm, and it refers to a cellular aspirate comprised of follicular cells arranged in an altered architectural pattern with significant cell crowding and microfollicles. The risk of malignancy here is 15 to 30%. And in the Bethesda system, the terms follicular neoplasm and suspicious for follicular neoplasm are equally acceptable, but the term suspicious for follicular neoplasm is preferred by some laboratories because some of the cases that fulfill the criteria for a follicular neoplasm cytologically, they prove not to be neoplasms. They don't have a surrounding capsule of the neoplasm, but they prove to be hyperplastic proliferations in a nodular goiter, where we have an increased number of microfollicles but no capsule. So the term suspicious is better for and provides a rational framework for cytologic histologic correlation. The possible histologic outcomes of this category is that the nodule is actually neoplastic, and this is the diagnosis in 65 to 80% of cases. Most are follicular adenomas, but a few are follicular carcinomas in 15 to 30% of cases. Cytologically, we cannot distinguish the follicular adenoma from carcinoma, and it is a histological diagnosis where we have to see the capsular and the vascular invasion. Some prove to be hyperplastic proliferations, like I mentioned, in nodular goiter, and rarely they are parathyroid adenomas, which cannot be differentiated from follicular neoplasm, but this is rare. And in rare cases, it is papillary CA, the follicular variant, when we have ill-defined nuclear features of papillary thyroid carcinoma and cannot be diagnosed as such. A few images of suspicious for follicular neoplasm cases. Here we see the microfollicles, small ring-like formations. Here we see significant cellular crowding and again microfollicles. The next neoplasm that still belongs to class 4 or 3F, it is the follicular neoplasm hartal cell type and refers to an aspirate that consists almost exclusively of hartal cells, more than 75% of the population. The hartal cells are metaplastic follicular cells with abundant, finely granular eosinophilic cytoplasm. And these cells are commonly increased in lymphocytic thyroiditis and multiple and multinodular goiter. They are hyperplastic conditions. We cannot distinguish again the hartal cell carcinoma from an adenoma. Again, we have to see the capsule invasion and the vascular invasion. And the nuclear atypia is an unreliable feature for this distinction. For example, a carcinoma may not be as malignant because it may be a well-differentiated carcinoma, but still we can have a vascular or a capsular invasion. And we can see atypia in lymphocytic thyroiditis and multinodular goiter, so we cannot differentiate. Here we see the hartal cells. You can see the abundant eosinophilic cytoplasm. Sometimes we have binucleation. Again. The next is the class 5 or Thy4 of the British Association. It is the suspicious for malignancy category. The risk of malignancy is 60 to 75%, and it is a heterogeneous category. But in most cases, we have the suspicion for papillary thyroid carcinoma. But sometimes the suspected malignancy, it cannot be specified. So we say suspicious for malignancy, not otherwise specified. And it has some features raising a strong suspicion for malignancy, but the findings are not sufficient for a conclusive diagnosis. The reasons for this diagnostic uncertainty is suboptimal sampling or preservation. For example, we may have air drying, degeneration of the cells. Sometimes we have, when we have an unusual variant of papillary thyroid carcinoma, usually the follicular variant, or the medullary thyroid carcinoma, they have unusual variants and it is difficult to diagnose. When we have overlapping cytomorphologic features with other thyroid conditions, for example, in lymphocytic thyroiditis, in cystic degenerative changes with reactive atypia, when we have carbimazole or radioiodine treatment, and we have significant atypia that we expect in these cases. The aim of this category is to separate this suspicious category from the next malignant category and to preserve the very high positive predictive value of the malignant category without compromising the overall sensitivity of the procedure. And this interpretation indicates to clinicians the less than definite nature of the diagnosis and allows for alternative management options. For example, surgical lobectomy with the intraoperative frozen section before total thyroidectomy is performed. This is a case where we put it as suspicious for malignant. We have a few ill-defined intranuclear inclusions, which are the characteristic of papillary thyroid carcinoma. And we have a significant cellular crowding and overlapping here. The next is the class 6 of the Bethesda or Thy 5 of the British Thyroid Association. It is the malignant category. It has a risk of malignancy of 97 to 100%. And the most common malignant neoplasm is the papillary thyroid carcinoma in 80% of cases, with the characteristic nuclear features, which I will describe later. Precise subtyping of the different variants of papillary thyroid carcinoma may not be necessary in FNA sample. It is not may not be possible on FNA samples, and it is also not necessary because the treatment is the same. Histologically, it's very important to diagnose these variants because they have different prognosis. A few words about the variants of the papillary thyroid carcinoma. We have the follicular variant. Some of these variants have the classic nuclear features of papillary thyroid carcinoma and can be easily diagnosed as such. But some have only subtle nuclear characteristics, and they might be diagnosed as suspicious for follicular neoplasm due to the increased number of microfollicles that they form, or suspicious for malignancy. The previous cases that I described, only cases with definite nuclear features should be diagnosed as papillary thyroid carcinoma. We have the macrofollicular, we have the cystic variant, the oncocytic, Warthin-like, the tall and columnar cell variants, which are cannot be diagnosed cytologically. These are histological diagnoses. Here we see a papillary thyroid carcinoma. We can see the characteristic papillary architecture. We can see, when you see closer, we can see well-defined internuclear inclusions, for example, here. And here we see a multinucleated giant cell, which is very often seen with the papillary thyroid carcinoma. Here we have another image, the giant cells here, and some of the inclusions here. And the next case, the architecture, the papillary architecture, And here we see the giant cell and neoplastic cells here. A few words about medullary thyroid CA. It is a rare malignancy of the thyroid, about 7% of the thyroid malignancies. It has a large number of variants, so this morphologic heterogeneity leads to significant diagnostic challenges in both cytologic and histologic specimens. It has plasmacytoid, polygonal, spindle-shaped cells, and the salt and pepper chromatin is very characteristic. Amyloid can be recognized, but sometimes it can be confused with thick colloid, so it's very difficult to diagnose. The differential diagnosis includes hartal cell neoplasm and papillary thyroid carcinoma if we have intranuclear cytoplasmic inclusions. Sometimes we have inclusions in medullary thyroid CA. And sometimes we cannot classify further, so with say not otherwise specified. Very important is the serum calcitonin levels and the carcinoembryonic antigen levels. And when the clinicians, they have a suspicion for medullary thyroid CA, it is very helpful to measure the serum levels of calcitonin. This was a case we had. It was written as suspicious for medullary thyroid carcinoma. We can see the spindle-shaped cells. Here we see a giant cell. And here we have some substance, it's possibly amyloid. It was confirmed histologically that it was a medullary CA by a spinal metastasis because the primary tumor, it was inoperable. A few words about the rare malignant neoplasm, the poorly differentiated carcinoma and differentiated metastatic tumors, for example, from the lung, breast, which are very rare. And most of these neoplasms, they cannot be, they are, we say malignant, not otherwise specified. We cannot distinguish between these. Definite diagnosis is made by histology and possible with some immunohistology. And the lymphomas, they are rare, very rare, and we have the non-Hodgkin lymphoma, the diffuse large B-cell lymphoma, and the multiple lymphoma. We have an increased incidence in lymphocytic thyroiditis. A few words about the parathyroid gland. Parathyroid lesions, hyperplasia, adenoma, carcinoma, and cysts may be mistaken clinically as thyroid nodules due to their intimate anatomic location in the thyroid area. And furthermore, the cytological findings are morphologically similar to those of the follicular lesions, and without clinical and sonographic correlation, differentiation between the two is very difficult or even impossible. The smears are cellular and they show dispersed single cells. We can see also formations that resemble microfollicles like in follicular neoplasm of the thyroid. And sometimes we may have pseudopapillary structures with variable amounts of proteinaceous fluid, which can resemble the appearance of colloid in the slides. Sometimes we have lymphoid cells, and when we see fat cells, it is an indication for parathyroid hyperplasia. And the last slide, the basic cell types, we have the chief cells, which have scanty cytoplasm, and they resemble thyroid follicular cells. We have the oxyphilic cells, which resemble the hartal thyroid cells. So it's very difficult to differentiate between thyroid and parathyroid. We have the clear cells and the transitional cells. And the measurement of parathyroid hormone is very important in needle rinses and in serum. So it is very helpful in the differential diagnosis when the clinician suspects parathyroid adenoma. And also cytology cannot differentiate parathyroid adenomas and carcinomas. Okay, that's it.